I'll finish reading. I'll give you.
I'm trying to remember what the injuries. Yeah, one had like a.
We have called this. And with this is what you think she will do.
That's
And she will have to invent.
Yes, she will.
Yeah, I'm not worried about the coyotes.
Well,
Hey, Alicia, do you want to go on mute just for a minute until we get started? Thanks. All right, good morning, everyone. My name is Melissa Southard, and I serve as a Deputy Director here at the Nevada Health Authority. I want to welcome you all to the Advisory Council on Graduate Medical Education meeting. Today, I will be facilitating our meeting for all of us. So with that, I'm going to call the meeting to order with the roll call. So we'll go ahead and get started with that. So Dr. Paul Hoffman.
Present.
Thank you. Dr. Allison Netsky.
present.
Thank you. Dr. Wolfgang Gilliard, sorry.
Yeah, present.
Thank you. Dr. Ross Berkeley.
Present.
Thank you. Dr. Brett Frey.
Here.
Thank you. Robin Dunhorst.
Present.
Thank you. Christine Bossing.
I'm here.
Thank you. Mason Van Halen.
Here.
Thank you. Dr. Jeremy Kilburn.
Here.
Thank you. Dr. Leon Raven.
Present.
Thank you. Vance Farrow.
Here.
Thank you. Dr. John Packham.
Here.
Thank you. And Stacy Weeks.
Here.
Thank you. All right. So with that, we'll move on to our next agenda item, which is public comment. No action may be taken upon a matter raised under public comment unless the matter itself has been specifically included on an agenda as an action item. Comments will be limited to 3 minutes per person. Persons making comments will be asked to begin by stating their name for the record and to spell their last name and provide dmastros@nvha.nv.gov with written comments. Comments must be provided up to and including the day of the meeting for inclusion on the record. And with that, I would like to call for public comment. If you'd like to provide public comment, please use the raise a hand on the Teams platform or just raise your hand in the room if you're in the room.
My comments can probably go under public comments.
Yeah.
My name is Julie Fazina. I represent Senate District 12, and I just wanted to thank everyone so incredibly much for being here for the first GME Advisory Committee meeting. The week I was elected in November of 22, I started holding stakeholder meetings with all of our universities around the state, with hospitals, with the governor's team as well. And one of the things that really came forward was the importance of bringing back this advisory committee and including the deans on the committee. And I was honored in 2023 to bring forward SB 350, where we created this committee. I hate that it's now 2025 and it took so long for the first meeting to happen, but I'm thrilled that it's here. And I was honored in 2025 to bring forward SB 262, which moved this from OSIT to HealthLink under Stacey Weeks, and allocated millions and millions of dollars toward GME in the state. So thank you all for the work you're doing for healthcare. I'm so honored to be among the presence of the people who are making healthcare happen and making it more accessible for people in the state. Thank you. I plan to leave after this. I just really came to say thank you to all of you this morning, and that was it. So thank you.
Thank you.
Thank you.
Thank you for that public comment. Do we have any additional public comment? All right, seeing none, we will go ahead and move on to the next agenda item. So next we have welcoming remarks and introduction to the Nevada Health Authority. So I'm going to share my screen if you all bear with me for one moment, and I'll turn it over to our director, Stacey Weeks.
Well, good morning, everyone. I, again, went to the wrong office. This is the story of my life. So I was like, I'm here, Melinda, and there was no one in this other conference room. So I apologize. I need to learn to read my calendar better. But good morning. It's good to see all of you. I know Melinda's pulling up the slide deck. I don't want to spend too much time on I want to make sure you guys know kind of where we are as the new authority and sort of what we're doing around workforce. But I will just say, from our perspective, healthcare workforce is the most important thing we can be doing right now in improving access, especially GME. If we're really going to meet the goals of what we want to do as a health authority or any of the healthcare goals we have as a state. Melinda, you can go to the next slide. Just to remind, I think some of you have seen some of these slides, so I apologize. I think Chris probably saw some of these yesterday. But just as a reminder, the governor, I think, did a really nice job explaining sort of the goals behind the health authority. We have a lot of healthcare programs and health coverage programs at the state that we run and oversee, and we contract with multiple vendors. We also set a lot of standards in the market, especially in Medicaid. People often think that we're, Medicaid is sort of, the kind of the low end of the pole, but Medicaid makes a lot of money in the market or spends a lot of money in the market and has a big role in setting some of those requirements. And we think we have an opportunity to get a better deal for the state when we look at other markets that don't have as many covered lives and as much money tied to them. And how are we getting the best deal, not only for the state, but for our consumers? And then where can we leverage all of the requirements that we put forth in our contracts with various vendors and carriers and providers to really streamline the markets. Next slide. So just a snapshot of kind of where the big programs are that we have at the Health Authority. We have our Public Employees Plan. We have Nevada HealthLink, which is our state exchange. We have Nevada Medicaid, which used to be the Division of Healthcare Financing and Policy under DHHS. Now DHHS is its own Department of Human Services. It focuses primarily right now on direct care and direct services, as well as child care, SNAP, food stamps, and TANF, which is cash assistance to families that are in poverty. Under the legislation that passed last session, there was direction to us to hire a vendor and work with DHS to put together a plan to move public health over. So I just want to know when people are like, well, what about public health? Public health is health. And I believe all these things are important together. So we are looking at how do we move over public health and coming forward next session with a plan to do that and kind of how we would restructure that. Obviously, that has not started. I will just say we are waiting to hire our chief of staff who will be leading that work for us, as well as get a vendor on board, but we will be having plenty of stakeholder conversations around that. And last but not least is our Battle-Born State Plan. Many of you may know it as the public option. It comes online in the market in January. So it'll be an open enrollment this year in the exchange. Next slide. I think to point out here, we have set our vision and mission. A lot of this really was set forth in statute, but in a lot more words. So we tried to simplify it. I think the biggest thing here I'd like to note, and I think it's really relevant to GME and all the work and healthcare workforce that we're trying to do, is reliable healthcare. We can create really great health insurance programs. We can create really good streamlining, all those things. But, none of this matters if we don't have the access in this state. So we need reliable healthcare. And so that to us, I think is one of the pieces that's really important. and all of the things that, especially that your committee will be doing, will be helping us ensure that there is access to reliable healthcare. Next slide. This is our team. I'm very proud of this team. A lot of them you may know, and some of them may be new to you. Some of you may not know Sandy. She runs, she is kind of the core of our engine, has been with the state for a very long time. And we're very grateful that she is still with us and helping us build out many of our new systems and technologies that we're going to be doing. She's also over our APCD, which is all payers claims database, which we hope to have up and running hopefully next year. And we can start to look at data across all of our markets, right? Not just the ones that we have right now contracts with, that we could actually look at the private market and claims data. We will be hiring a chief of staff soon, hopefully at the end of October, and I'll be happy to announce that soon too. And then Lynette Aaron, some of you may know, she's our finance director. And then Melinda is over all of our community engagement and workforce development. At the bottom here, you have 4 divisions. Todd Rich is over healthcare purchasing compliance. That includes all of our contracts and purchasing, some of the stuff we're going to be doing in the healthcare space, which we're excited about. And then also our new Medicaid Inspector General Office, which used to be under DHCFP, which is now Nevada Medicaid. So we moved that out to ensure its independence from the program and providers, because often the program has to have relationships with providers. It's really hard when the program is also kind of having to be the bad guy. So moving that out and ensuring there is that independence and looking at provider waste and fraud and abuse, and working very closely now, which I think has been a really great partnership with HCQC, which is the state's licensure for facilities. So hospitals and all of those healthcare facilities in the state, we are licensing and overseeing those under this division. Jennifer Krupp is over consumer health services, which includes our exchange, our battle-born state plans. She's also over our Medicaid eligibility policy. We did used to that policy decisions lived under the original DHHS under DWIS. It's now Division of Social Services, and it's still under DHS. We took the policy back because we are the single state agency and have authority and responsibility to Medicaid at the state level. We still work with DWIS or DSS to conduct the eligibility and enrollment. We are phasing that into our exchange too over time, but we still work with them, but we actually hold the accountability with the federal government and ensure that they're following all the rules. So that is a different relationship, but I think gives us the ability to be more accountable to CMS as the single state agency. Teresa Karsten, some of you may know her. She used to be over our managed care program in Medicaid and used to basically hold court with the health plans, and is now over our public employees benefits program. We're very excited to have her there. And then Ann Jensen, she is our newer member really to the team, I would say, and newer to the state. And she is now our Nevada Medicaid director, and very excited to have her on our team. Next slide. All right, just high level, our 4 goals that we've set forth. We're going to be creating a strategic business plan, and GME is going to be part of that, and some of what you guys put forward and goals. Especially we'll be working around number 3 and really expanding our state's healthcare workforce to meet the needs. Also just want to point out that all that you're doing in this space really impacts number 1 as well, and number 4 too, but number 1 especially. When we look nationally, we are not doing well. I think that's probably unfortunately not a surprise to anyone, and I think that we all own a piece of that in some way. If you are working in healthcare in this state, we all have to take ownership of it and work together. I always try to highlight kind of where we're at. I used to think when I was in Arkansas growing up, well, at least we're not Mississippi because they were 51st always. And now it's different. Nevada is 51st in a lot of things. As you can see here, it's still the bottom 10. So our goal is to get us out of the bottom 10 over the next 3 to 5 years. But all of these things that we're doing together will be very important to that effort. Next slide. You may say, Stacy, there's no way you can do that. And I sometimes wake up in the middle of the night thinking the same thing, but it's not just me. It's not just our team. It's all of us together. And I think this GME Advisory Council is part of that partnership. And all the stuff that we're already doing with UNR and we're starting to do with UNLV, I think will be really important in this space. But we have a footprint of 1 in 3 Nevadans. When you think about who we can impact as an agency, our coverage program covered that many people, and that is a big impact. We also cover 1 and 2 births. Medicaid has to own the Medicaid or the maternal health problems. We have to be owning that because we are covering and paying for and setting the requirements for 1 and 2 births in this state. So we can do better in this space. But I just wanted to point out that these are our markets and we do have a pretty large footprint to have an impact. Next slide. So how do we get there? We are trying to just reimagine and get creative, right? And there's so much new technology too that we could probably be leveraging differently. I think luckily there's some new funding coming. We'll talk about that in a minute. In the rural areas, I think we can actually look at new technology, AI. There's always a risk with AI too. I will tell you, there's like AI that's good, and then there's AI that's bad. I'll say on the fraud space, we're seeing a lot of AI create actual medical records and actual x-rays and AI that's really fraudulent and looks like a real claim. So there's a double-edged sword with AI, but we want to take the good parts of it and see where we can do better and actually make things easier for our providers and consumers. Next slide. First, first is really making our providers happier, and because it's a big piece of it, right? I mean, maybe we can get GME slots, we can get people to stay here, but will they actually serve Nevadans and 1 in 3 1 in 3, which is who we serve at the MBHA. We're looking at all of our markets. Where can we streamline the experience? So let's say we have one enrollment process with MBHA, which they already enroll with us now for Medicaid. They enroll in some way with PEP through multiple contracts with the TPAs. They also enroll separately for all their private individual market products and contracting, right? So it's a lot of burden. How do we make it where if a provider comes to MBHA, we screen them, we enroll them, they agree to certain, standards, credentialing, we do all their credentialing, and all the markets honor it. What if we could do that? What if we could start there? And then looking at once we do that, with our carriers and our markets, can we require that they not have 50 different quality metrics and standards, that they're aligned in some of the key areas that we're all wanting to focus on? And so it is a simpler experience for everyone. So that is where we're trying to look at how do we do that. There may need to be some statutory changes next session. We'll know more when we get there. But these are the things we're working on. Medicaid already has centralized credentialing, so providers in Medicaid don't have to be credentialed 5 different times. They have one-stop shop. And all the MCOs honor that now, including our DBA. So that's the first step. And then we're also implementing some of the prior authorization bills that passed last session, or the big one that passed. And we are working to streamline there. But as you guys know, PEP was exempt. Some of the private market, while it is not exempt, it's, or how are we overseeing that? So there's opportunities, I think, for us to take those standards and align them across all our programs that we have contracts with carriers. So we'll be talking more about that in the future. Next slide. All right. This is one I'm very excited about. It's going to take us several years and it's gotten more complicated because HR 1 passed and now we have work requirements to implement. And that actually makes what we were trying to do to make eligibility and enrollment easier, simpler, less stigma. Someone can do it in their own home or at a kiosk online in real time and do shopping for Medicaid managed care plans. Now we have this work requirement thing that's really creating some system challenges, right? Like, how do we do this and lifting this project in a way that we're not paying for it twice, right? In our legacy system and then again in this new system. So this may be a little more delayed than I wanted it to be, but we're hoping by January 1, 2027, we'd have this up. But I think it's going to be probably a year or two because we want to do it right. But our real goal here is to become not just a determination state for Medicaid eligibility and enrollment like other states, but go that extra step that was really envisioned under the Affordable Care Act. That it would be fully integrated system where people could go online. They don't know if they're Medicaid. They don't know if they're private market. They know they don't have employer coverage, right? But they just need help finding coverage. They don't know if they're eligible for premium tax credits. They go in and in case you didn't know, Medicaid, premium tax credits, and exchange coverage all use the same logic. Which is based on tax returns. It's called MAGI. It's modified adjusted gross income. They all use the same logic. So they use that logic and it figures out which program they're eligible for, enrolls them in real time. And what will be really nice for our Medicaid recipients and good for our market is they can shop and compare their health plans. They get to see what value-added benefits, which are the extra benefits plans offer. They get to see what standard coverage, what quality rankings the health plans will have, what networks they have, just like anyone else who shops for health insurance. So we're hopeful that this will really improve our market and the experience and also get at some of the things that we're hearing in the community about, and especially our rural areas where My grandfather's the same way. He refuses to get on Medicaid to this day. And so it's just been this whole thing where people don't want people to know. They don't want people to know they're on public assistance. They don't want to go to the welfare office, but they can do it in their own home. We're hopeful that this maybe removes some of that stigma. Next slide. And then last but not least is looking at purchasing, which is kind of my favorite part of all this, is like, where can we really leverage the contracts and the money that we pay these carriers to do better for the state and the marketplace. Medicaid is an $18 billion program. Managed care plans are going to have about 75% of the market. So that's a lot of money over the next biennium. We have a lot of leverage when it comes to Medicaid, more than the private market. So this is something we're looking at, and then also thinking, through how do we simplify all the rules and requirements across all these contracts. So it's easier for us, it's easier for you, it's easier for our consumers. Last but not least, we are doing a single PBM. That bill passed last session, and so we're standing that up first for Medicaid across all of our MCO and fee-for-service, which is a pretty large lift. And we're also working toward eventually allowing some option for the public employees to buy into that. That allows the state to get better, to set really some of those prescription drug lists, for example, but also to get some of those rebates, pharmacy rebates back. Right now in Medicaid, we're doing a really good job just with our single PBM on fee-for-service. We're getting about $400 million a year. So we're hopeful that will be even more under this new opportunity with single PBM. Next slide. Melinda, am I doing all these? I forgot. Are you doing these? You want me to do this one?
Yeah, I had you doing these, but
I can
let me
do
know
it.
where
It's fine.
you can jump
Yeah.
in.
Okay. So, MBHA, we can't do everything, but I want, but there are some of the, we have some levers, right? And the three I think on this side are important, and what we can impact is really increasing provider participation. One of these is through this advisory council, but also so it's both one and the expanding that pipeline. So both of those we feel like can be impacted by this advisory council and other efforts that we're doing at MBHA. And then the other piece that we really know has a large impact that we really need to look at is sort of that provider reimbursement and billing experience. Obviously, all of this costs money. So we have to also leverage sort of our financial situation sometimes in the state. But the Rural Health Transformation Grant is another big opportunity that's coming up soon. And Melinda is working hard on that. And I think could be leveraged too for some of the residency pieces in rural areas. We believe strongly in the governor's proposal as part of the 1332 waiver in the Practice in Nevada program, which would provide loan repayment for providers willing to live and work in a region. But we're tying a contract with that individual that they have to live for at least 4 years in those areas, or they have to pay their money back, and they're not getting it all up front because, some people run with the bag. This program has worked in other states and has helped people stay a long time in their communities. So we're looking at ways to fund that, but prior to when we get that 1332 waiver money. Next slide. Just real quick, I mentioned the Rural Health Transformation Grant. Unfortunately, we have a very short timeline. The governor has asked MBHA to lead the application. Melinda's leading it and is going to DC next week for some conversations with national folks and experts in other states on this. Our application's due November 5th. We are collecting feedback. Melinda can share that link to the survey, or you can email it to her. We're doing our best to get all the ideas and then to summarize them for a public workshop October 2nd at 2 p.m., which is coming up really soon. And then to get more feedback, and then hopefully we will do a second workshop before we submit, so you guys can see where we landed and where the governor's office landed with us. Next slide. These are the buckets that the grant asks us to work on. As you can see, workforce is a big one, which you guys are very much involved in. Prevention and chronic disease, innovative care, appropriate care, technology innovation. A big thing, I think, from the governor's office, and also just given our experience with ARPA funds, is that we don't want to just hand out a bunch of money to a bunch of different projects and studies that have no long-term sustainability and don't really have a long impact on the infrastructure. Because this funds, if you may not have been following the HR1, but if you were, you might recall that when the rural hospitals lose under the bill anywhere between 70 to $100 billion. This is only 50 billion, but it was supposed to help people like Senator Murkowski in Alaska and others come along for their rural hospitals. So we're trying to be very mindful. Everyone wants a piece of this pie, but I'm gonna be very honest. It really needs to support our rural healthcare systems and our local hospitals, which often are those rural are the only healthcare provider in those areas. So we're very sensitive to the fact that this money is supposed to help increase their infrastructure and their workforce in those communities. Next slide. Oh, that's it, Melinda. I'm done. Thank you. And happy to answer any questions, but you guys have quite the agenda. So happy to also just be quiet.
Any discussion from the council? Perfect. Well, thank you, Stacy. Appreciate that. So we'll go ahead and move on to the next item in our agenda for council member introduction. So we wanted to give all council members the opportunity to introduce themselves. And then in your introduction, I would like you to also provide, what are your goals for serving on this committee, and, so speak to what your why is. So I'm going to go through the roll call sheet, and I'll just call on our members, and we'll go through it that way. So I'm going to start with Dr. Hauptman.
Well, good morning and thank you. Paul Hauptman, I'm the Dean at the University of Nevada Reno School of Medicine since October of 2022. Very pleased to be on this advisory council. The growth of GME is obviously extremely important to everybody on this committee. And I want to thank Senator Pezzina for all her efforts in the last two biennial sessions to get us to this point. The vision of UNR Med has been and continues to be a healthy Nevada, so we're very much aligned with what Stacy Weeks has just talked about. And we're a big believer that we have to grow GME because, as John Packham may share with you, retention rates are so much higher once you get someone into a residency or a fellowship program.
Thank you.
Thank you.
Appreciate that. All right, so we'll move on to Dr. Allison Netsky.
Good morning, everybody. Allison Netsky. I'm the current interim dean at the Kirk-Kerkorian School of Medicine at UNLV. I have been here in Las Vegas since 2007 with both medical schools, and really have been pushing the envelope for the development and creation of GME programs in Southern Nevada since day one. We've had enormous success with the creation of new programs and the expansion of other existing programs like our psychiatry programs, our critical care. We've with the previous programs in GME expansion, we've been able to double our footprint in OBGYN, psychiatry, and other programs. And we're seeing a lot of fantastic success. Unfortunately, our population is growing so much and we have so many doctors retiring. We really haven't been able to keep up. We have so many important partners in every sector here in Southern Nevada that are on board with supporting this mission. And I'm excited to be here to be part of that.
Great, thank you. All right, we'll move on to Dr. Wolfgang Gilliard.
Good morning, everyone. I'm Wolfgang Gilliard. I'm serving in the capacity as Dean and Chief Academic Officer at Touro University, Nevada, at the College of Osteopathic Medicine, which is such a mouthful that I tell our students just say Touro, Nevada, and everybody knows where they are from. I feel honored to be, I think, in a way, a senior dean, because I've been in the deanship for 7 years plus here at Touro. And we have, as many will know, that Touro actually was founded back in 2004, 20 years ago, to really fulfill the healthcare workforce needs and to really grow our own physicians. We are now at 180 graduates approximately per year. And that means that there's a lot of students who would like to stay. Our first goal is to have them stay. And as you know, if you do your medical school and your residency in the state, there's a 75% chance of you staying. So we are all working together with the other medical schools, with Dr. Netsky, Dr. Hauptman. I really feel it's a wonderful camaraderie, a good sense of exchange and a common mission. And this year we had 55 of our graduates actually staying in the state, and over 50% actually are going to primary care, which is internal medicine, family medicine, and pediatrics. So I really think that the pipeline, if you want, or pathways, if that's a better word, that we have is actually there. We now need to increase A, the numbers of residency spots available, and B, the variety of it. And so with that, I think we have a common mission. We are using any which way we can, private, federal support to do that. And I cannot tell you how excited our students are. And if I can leave you with this one thought, that is my wish to say, is I have never had such good medical students to educate as this generation right now. I would love to leave that thought because they are coming with motivation, they're coming with dedication, and they have a social commitment to society, to communities. And when you ask them, that's what drives them. And that's what actually drives us. And I like to say, happy students makes happy faculty makes happier communities. So with all that good thing that I just said, I have a little sad news. Another state called Florida was able to recruit me. And as of October 2, I will be relocating to Naples, Florida, as the inaugural dean of a brand new medical school. And they are, they knew how to get me. How is that? So I'm very sad about that, but I would like to offer, and actually I'm honored that Touro, Nevada made me a dean emeritus. So we are working together. I continue to work, and I would like to commend and recommend the interim dean, Dr. Paul Kalikas, who is chairman of our medical school, and he has been in the Valley for over 20 years, and everybody knows him as associate program director at Valley Hospital. He is the perfect person to be the interim dean. He actually served as the role when they hired me, and then until we have a new dean, I would like to recommend him and then the others to be on this, and I will give them feedback and tell them how important this committee is and task force, and I enjoy working with everyone, as you know. Thank you very much.
Congratulations.
Yes, thank you for that. And I'm so sorry that we get to meet you and then have to say goodbye, but really excited
Yeah.
for this next adventure for you.
And that's why it was important for me to be here in person, because this is one of the things that actually Shelley Berkeley, when she hired me, came to me face to face and said, you know, we are not hiring just a dean, we are hiring someone who helps the community. She was very
Wonderful.
clear about that, very clear about that. So thank you.
Thank you so much. Okay, we'll move on to Dr. Ross Berkeley.
Yeah, nice to meet you also. I'm an emergency physician. I've lived here in Las Vegas for 25 years. My entire career has been dedicated to quality improvement of patient care and medical education. I helped found the emergency medicine residency. We actually sat together as a group back in 2003 and said that this state really needs to have an emergency medicine residency. So I love being involved in this. I think this is an incredible opportunity for our community and for the entire state. And just really looking forward to trying to make a positive impact here.
Wonderful, thank you so much. All right, and Dr. Brett Frey?
Thank you. Brett Fry, I am an emergency physician like Dr. Berkeley. I've known Ross for many years. We've worked on a number of projects statewide. I serve as vice president on the State Board of Medical Examiners, and we often have discussions on healthcare disparities and workforce issues. So this is it's an honor to sit on this committee at the direction of the governor. Also, I serve as interim chair of emergency medicine for the School of Medicine in Reno, and then also serve Renown Health System, the trauma system, with my group, Western Emergency Physicians. And I know Dr. Berkeley and I were unique canaries in the coal mine for all the healthcare disparities that really show up on our doorstep at some point. And I think that that would be my goal, is to help this group, I guess, identify from a real world perspective, because 30% of our admissions come from the rural counties in Nevada, which is a pretty large number. We see late presentations, which cause lengthy hospital stays, which cause worsening outcomes. So to the degree we can have folks interface with any aspect of the healthcare delivery system in Nevada earlier, because they have access is just going to be much better. So thank you.
Thank you. And I'm sorry for mispronouncing your name. I got it now. All right, we'll move on to Robin Dunkhorst.
I think she's got a note there, Melinda, that she's jumping on a plane there. I'm just looking on the
Oh,
screen.
no.
Yeah.
Okay, no problem. Thanks, Mason. Okay, so Chris Bossy.
Thank you, Melinda. So I'm Chris Bossy. I'm the Chief Government Relations Officer for Renown Health. I've worked in GME at some aspect of GME for more than 20 years in Nevada. And, you know, my why is similar to what I've heard many of you say. We just need more. we need to be able to train more, both north and south. Since the schools, we now have multiple schools. When I first started here, we didn't have multiple schools. It was just UNR. I'm excited that we have resources and we have an opportunity to kind of do a gap analysis and focus on where we need to grow strategically. So I'm excited to be able to participate.
Awesome. Thank you. All right, we'll turn it back to Mason.
Morning. Thank you, Melinda. Good morning, everyone. I'm Mason Van Houweling. I'm the Chief Executive Officer of University Medical Center, which is the state's largest public hospital. And we do our fair share of training at UMC. We've got close to 4,000 students that come through our doors every single year. But when it comes to residencies, we're partnered with UNLV on those programs. So I think, you know, just high level, some of our goals, or at least mine, would be for this committee to create a statewide GME consortium where we could perhaps leverage each other's resources, and whether it's sim labs or libraries and those type of things. I know with these programs, historically, sustainability is a challenge. So how do we provide sustainability? How do we increase research? Maybe finding outside grants to be able to help fund and drive some of these programs. And then, as Stacy mentioned, rural health is extremely important for the state of Nevada. So look forward to serving with everyone.
Great, thank you so much. Dr. Jeremy Kilburn.
Good morning, everyone. My name is Jeremy Kilburn. I'm a critical care pulmonologist, active duty Air Force. I've been in Las Vegas since 2011, which is quite a long time for the Air Force. It's kind of like dog years. So in that time, I've helped set up the largest military-civilian partnership in the country, currently working with Mason at UMC and Dr. Netsky at UNLV. We sponsor 41 GME positions, which is the largest amount in the country, provide a lot of faculty. When I retire here in June of 2026, I will be staying in Las Vegas, Nevada, and practicing. So it's not just GME that the military can help with in terms of recruitment and retention into Nevada. Our active duty force, I don't have the exact numbers, but it's around 25% of our physicians will stay in Nevada after being stationed here. In addition, I worked quite a bit with the VA hospital. Obviously, anytime we can bring federal healthcare dollars to support GME, that's going to be really important. So that has been my passion, to leverage any expertise or experience I have with the federal government to help with Nevada, specifically where I am in Las Vegas.
Great, thank you for that. All right, moving on to Dr. Leon Raven.
Good morning, everybody. Leon, I know quite a few of you here, so nice to see everybody here. I represent the Division of Public and Behavioral Health. I have been with the state government since 2006, so like 19 years. Well, I'm really glad to be on the table here, at the table here, to see how the state can work with our training departments in various disciplines. We're mostly focusing on psychiatry because that's the kind of work where the state has clinical services, but we very much would like to expand our collaboration with other disciplines where we can, And overall, just I would be happy on behalf of the state government to support this group in developments of future GME programs.
Great, thank you. Dan Sparrow.
Morning. Vance Farrell, Healthcare Industry Specialist for the Governor's Office of Economic Development. I've been in this role now for 13 years, and it has flown by very quickly. I remember one of the initial questions that I was posed with, they said, well, how are we going to grow our physician workforce? I said, well, we're going to have to cheat. We're going to have to grow it from both ends. We're going to have to do the residency programs, and we're going to have to build medical schools, and we're going to have to meet in the middle. And we have literally been doing that for the past 13 years. I can't tell you how happy I am that this is happening at a time when the rural economic development dollars are about to be a tsunami wave that's going to wave across this country, and in Nevada in particular, where I hope we can take the opportunity not only to create more GME programs, but quite possibly new partnerships with our rural hospital partners and embed a rural experience in each of our GME programs, because I think that is critically important to those communities as well as to our state as a whole. And of course, bring in other innovative opportunities that can revamp some of the community needs in those rural areas and make that experience even better for our students and for our residents. So I guess that's my why. I'm very happy that the timing of this is what it is. And I think to your point individually that you said, also looking at the variety of what we've done in the past and what we can look to do in the future. I think now is the time that we could potentially look if the funding will allow us to at some specialty areas that we need to consider. If we look at the data, and I promise you I can tell you that, for instance, Nevada bleeds out about 1.5 billion a year just in oncology reimbursements, and that's on the commercial side. We haven't even looked at the Medicaid folks that don't have the resources to go out of state to get care for care that they couldn't get. And so just underneath that is cardiology. So when we look at those dollars that are being reimbursed outside of Nevada, then that obviously tells us that we need more of these programs. And so I just kind of want to plant that seed because I think we need to also, and this is not me throwing a rock at primary care. It's just all of those primary care physicians need some place to refer to, and they need to have a strong ecosystem such that, you know, our families are less burdened. And so I'll stop there and just, that's it. Yeah, I'm just happy to be here and happy to see where we'll go from here.
Wonderful, thank you, Dan. All right, Dr. Peckham.
Good morning. John Packham. I'm Associate Dean in the Office of Statewide Initiatives at the UNR School of Medicine. I echo Dean Hopman's comments about the importance of this task force and the role it can play with workforce development efforts, particularly those up north and those that we're working on in partnership with Renown Health. This Office of Statewide Initiatives is a unit of the School of Medicine, includes a number of programs, including the State Office of Rural Health, including Project Echo Nevada, the Nevada Health Workforce Research Center, and a common thread throughout just about everything Statewide Initiatives does is health workforce development. And so I'm happy to be a part of this project and process, and we'll share a little bit of information later from our office to eliminate some of the issues we're facing.
Perfect. Thank you so much. All right, and then Stacy Weeks.
Well, good morning again. I already kind of said our spill here at MBHA. I'm just excited that we're meeting. I really want to give Melinda and Alicia on our team a big shout out for trying to get this done. I know we're all very busy and we had a cyber attack and everything else at the state level, but this is a high priority for us. And I really, really want us to get some decisions done and some money out the door. So that's my plug. I really want to see us start to move things forward. And I know there's going to be hard conversations, but I think just listening to all of you, we've got the right group to do that. So I'm very excited. And so just thank you for being here today. on a Friday.
Yes, thank you so much. All right, we'll move on to the next item on our agenda. Let me just get our presentation up one moment. There we go. All right. So for this section on the agenda, I just wanted to share with the council kind of, where we've been with GME in Nevada, and also with the advisory council, and then also what are our current fiscal status and then program status for GME, now and then looking into the future. So yeah, I just went over that. Sorry. Okay, so we're going to start with the history of graduate medical education in Nevada, starting with the task force for GME and advisory council. So this slide, while busy, I did want to give kind of a snapshot of, where it all started, right? So back in 2014, the governor had established the GME task force to provide recommendations to the governor on how to increase graduate medical workforce in Nevada. And there was a report that was due to the governor by the end of that year. So pending that, they then moved forward and signed another executive order the next year, November of 2015, which reestablished the GME task force. And then it also had some money with it, and it appropriated $5 million each year of that biennium to fund grants for GME. So this is really where we first saw the GME grant program. And this task force was meant to be an advisory body to the governor on graduate medical education. The Office of Science, Innovation, and Technology was meant to be the administrative support to this task force. And again, there was another report that was required. And then in this executive order, the task force was allowed to meet through the end of June of 2017, but then it was to cease to exist unless it was directed by the governor to continue to exist. So that did move forward. It did continue to exist and meet and appropriate grants. And then fast forward to 2023, Senate Bill 350 statutorily established the Graduate Medical Education Advisory Council and the grant program into Nevada Revised Statutes. And so the Office of Science, Innovation, and Technology continued to manage both the Advisory Council and the grant program. There was a specific process that, applicants were required to adhere to for applying for these grants. And it also gave some parameters in statute about how we were to prioritize those grants and get the money out to fund these programs. And then in that bill, there was also an annual required report starting October 1st that was required of the council duties and basically what had occurred. Then we move into just this year, so 2025. Our amazing bill, Senate Bill 262, which revised some of the grant program and gave some additional duties to the advisory council. So this bill transferred the program from the Office of Science, Innovation, and Technology to the would have been Department of Health and Human Services, now is the Nevada Health Authority area. And also this bill prohibits the grant recipients from reducing or eliminating the size of a GME program. There has to be a specific application process. If a grant recipient did want to reduce or eliminate the program that they had been awarded, they have to apply to the Nevada Health Authority to do so. And we are currently working on the application process right now. So just so you all know where that is in process. This bill also appropriated an additional $4.5 million each year of this biennium. And then it also incorporates Medicare caps into grant consideration, which is a new thing. And like I said, it added some responsibilities to the advisory council. And then, of course, Senate Bill 494, just this past year, transferred the advisory council and the grant program to the Nevada Health Authority officially. All right, and then I had a slide here of the members of the advisory council. So as you all heard, the amazing introductions of each of our council members, but each of these members is defined in statute, and we have specific terms listed here and on the next slide as well. Just to give you an idea of, when the terms expire and who's appointed where. Okay. And then this slide here, I wanted to highlight, the responsibilities of the advisory council, because there are some very specific ones. And obviously, the very first one is to evaluate the applications for the GME grant program, right? And when you evaluate those applications, then the council is to make recommendations to the Nevada Health Authority in funding those applications. In addition, there are certain priorities that the council should look at when they're exploring those applications, to give priority to the institutions that operate programs for residency training that are, of course, approved by the, is it the advisory council or the accreditation council? I always forget. For GME, the ACGME, which one is that? The advisory council?
You can just say the acronym.
Accreditation. Yes. That are training residents that exceed the maximum number of full-time equivalent resident positions for which the institution receives direct or indirect GME payments from Medicare. So this is something new that the council needs to consider in making those recommendations. Next, to study and make recommendations to the Nevada Health Authority, the governor, and the legislature concerning the creation and retention of Nevada programs for residency training and postdoctoral fellowships that are, of course, approved by the Accreditation Council and GME. So this, I think is really important. Dr. Packham is going to give us a lot of great information here in this meeting, and I think that, the council to come together and really, study and make those recommendations is going to be really important for shaping the future of our GME program in Nevada. Additionally, the council is to, make recommendations regarding the recruitment and retention of physicians. Which physicians do we need and why and where and all of those things. So that will also be really important. And lastly, the council shall also explore ways to use federal financial participation in Medicaid, which is a completely new thing for the council to consider in supporting programs for medical residency training and postdoctoral fellowships in Nevada. So just wanted to highlight those here, that those are going to be really important in our work moving forward. All right, now we're going to go into the grant program history. So on the next few slides, I just wanted to give a snapshot of the different rounds of funding that were awarded and to the different institutions or awardees. So the very first round, as you may recall, the task force met beginning in 2014, I want to say, might be wrong there, but the funding, was first made available in SFY 16. So the first round, the council had made recommendations and awarded all $5 million of the appropriated funds. Second, with round 2, same thing happened, right? We got a bunch of applications. The council made recommendations and awarded all $5 million. Next, moving into round 3. So this is SFY 18. In round 3, there were only 2 applications. So those applications were fully funded, but as you'll see here, the $5 million, there was still money left on the table. So the council decided to do another round of funding in SFY 18 and actually awarded almost all of it out to these applicants with, a little over $300,000 that was unallocated and had to revert back to state general funds because there was no, mechanism in place to balance that money forward. It had to go back. So next, then we move to SFY 19. So round 5. I just noted here that the UNLV School of Medicine addendum was to add a resident because only 2 of the 3 were funded in the last round of funding. So that additional $80,000 had added the 3rd resident there. So round 5, again, didn't award the full $5 million. So we still had money left to spend. So had a round 6 and we're able to allocate all of those fundings for SFY 19. Then we get to round 7, and you'll notice we skip forward to SFY 2023. And this is because like I said before, the mechanism was not in place to be able to balance forward that funding. And as you know, graduate medical education programs take a long time to kind of get started and get off the ground and get moving and get to the place where they're able to spend the money. And so, the funding that was allocated in those bienniums in between 19 and 23 had to go to pay for the subawards that were already funded, basically. So we recognized that was a problem, right? And we were able to fix that. I think the next slide talks about that. It doesn't. The next slide after this does. So 2025. Again, this SB 262 talks about some specific parameters around, giving priority to certain grant applications, and making sure that the scoring rubric is, as objective as possible, and really ensures that the applicants meet all of these needs wherever possible. Because really, we're trying to ensure the long-term sustainability and viability of the GME program in Nevada. And I think that, having these parameters there really means that.
And Melinda, just quick question. In reading this seems agnostic to prior awards in similar categories. So going forward, if there's for instance, a geriatric grant application, and there was a geriatric grant application awarded in that same domain, recently, I didn't catch where that's a consideration in the rubric.
Right. Yeah, that's a good point. So for, I think that's something that the members should discuss, right? When we talk about developing the scoring rubric and the way in which the council wants to, recommend the awards. And maybe that's something the council wants to consider is like, okay, well, did this program just receive an award, 2 years ago or something, just throwing it out there. But we will have a vendor that's going to be working with us to help to develop, present a proposal to the council for a scoring rubric and a way in which to score these applications in the most objective way possible. Thanks. Good question. All right, so here is the one. So SB 262 made sure, because that was the thing in SB 350 back in 2023, apparently that language next to the green check mark there was left out of the bill, unfortunately. They had tried in 2023, but it didn't get through. So now 2025, now we have the ability to carry forward money from each biennium forward. So if it doesn't get spent in that biennium, it's okay. It doesn't go back to state general fund. It continues to remain in that account to be able to fund GME programs in the state. Let's see, I think that is all that I wanted to talk about on that slide. All right, so now I want to move into the fiscal status and give you a snapshot of where we're at currently. Okay, so current budget status for the GME program in Nevada. So SFY 26, which is where we're at right now, we have basically our base funding, right? Base funding of $8.5 million-ish through the biennium. So that is appropriated just, as our base funding. And then we had the $4.5 million that was given to us. So each state fiscal year in this biennium, we'll have $4.5 million added per Senate Bill 262. In addition, we had about $7 million was remaining in the account from the Office of Science, Innovation, and Technology. So that money is going to be transferred to the account under the Nevada Health Authority. So it is balanced forward, which is amazing that we were able to get that going. So super excited for that. And then, of course, we have to, minus the money that was already appropriated to previous grants in that past round of funding. And then the outstanding payments that are due to the grant applicants from the last state fiscal year in Q4. So had to take those amounts out, and that leaves us with almost $16 million to award out this year. So
Linda, can you clarify the first and third entries. Is the third what was not spent from prior and the 262 then applies that you can carry it over?
Yeah.
Where's the 8.5? Maybe I'm not aware of how that was, where that comes from.
So the 8.5, I believe, is our base funding that's allocated each biennium to the GME program from here forward. So it started, I think, in 2023. There was 8.5 that was appropriated then. I could
So
be
it's in
wrong.
the governor's budget.
In the governor's budget.
So it's in
yes.
the permanent governor's budget?
That's what she's saying.
Yes.
Do you know for how
Yes.
long it's?
Yes, it's
It's-
permanent. It's just each year we'll have to put it back in. We could ask for more if we want to, but we have to show some success in this program, I think, given sort of the history. But the transfer over was a way for, I mean, Senator Pazina wanted to get double the money. So instead of losing that money to the general fund, which typically happens after it's appropriated, that was the transfer. But we also got what was already in the base too.
That's good.
And one more point, Stacy, so this last session, maybe the session before actually, the fines that the Board of Medical Examiners places on licensees, we made a change and they are going to help essentially healthcare delivery in the state of Nevada to improve outcomes. There may be opportunity on those fine funds, they're fairly substantial, to maybe direct them further to GME, because I think that would be a more defined role for those funds. So just a thought.
Yeah, I mean, I think we'd have to have evidence that the board and everybody wants to do that before we assume any of that money here. Like some sort of directive, because right now, I just don't want to, I think that would be helpful if the medical board approved that. If they
Well-
don't, you know.
Yeah, we actually carried the bill, which is signed into law, where that money no longer goes into the general fund, but rather is supposed to be directed by the state towards programs that elevate healthcare in Nevada. But we
Whose
don't
budget
know.
did it go into? Do you know?
I'll have to get that
Yeah,
specifically.
we'll dig into that with
Okay.
LCB, but my problem with, unfortunately, unless it went into our budget, we can't really direct it. And whoever's budget it went into, they'll decide. Unless, I think that's the challenge, but we'll look into
Okay.
it and see who it is.
Okay.
Just out of curiosity, what kind of levels of money are you talking about in terms of the annual fines that are levied? Is it more than a couple 100,000?
It's a little less than that, Ross. I would say best guess is about 250 to 300 annually.
Copy.
Great, thank you. Good questions. All right, so moving on. So now going into the GME program under the Nevada Health Authority. So we had deployed a survey to GME stakeholders. So we include the survey to teaching hospitals and prior GME grant recipients to gather information about what programs have been most impactful and helpful, and identify, of course, the barriers to any success. We had that survey live for about a week, and we had some great responses. So I just wanted to share those with you. So on the survey, we had asked, where would your organization expect to see the most benefit from GME funding? And, have them kind of rank it of like, what would be the most impact to the least impact? And as you can see here, the top three areas are really new residency programs, expanding existing residency programs, and new fellowship programs seem to be having, the most impact from survey respondents there. Some additional considerations that we got in like the free form text of the survey, noticing some challenges, right, to expand or grow GME programs in Nevada. So, resident pay in Nevada may be low in comparison to some other states. Our partner hospitals may not support resident training requirements. Medicare caps, I know, can be a difficult challenge. And then sustainability of funding for programs, of course, can be difficult beyond the startup or the expansion. So it's nice to have that, infusion of grant funding, right, to really get that started. But then it's like, okay, so how are we going to sustain that program? And then another one that we've heard is, meeting the housing needs, right, of residents and their families, and ensuring that that is not a barrier. Some areas where we have some opportunity for impact. Like we have a lot of survey respondents that said that we're planning for new programs. So exciting new ideas there. Opportunity for new federal and state funding strategies to help enhance graduate medical education. And considering some different ways to enhance training opportunities, really be innovative there. And different partnerships with different hospitals. That was all I had for that one. So I'm gonna stop sharing there. Do we have any questions, comments from the members?
I think just a quick comment about resident pay. I mean, it's very programmed. I mean, it's very dependent on the sponsoring institution. At UNR, we do a critical analysis each year of like-minded programs of similar size and in geographic region, and do a critical analysis of that. We want to be competitive. And we also recognize there's a major unionization push around the country for residents and fellows. So we want to remain competitive in that context.
Interesting. Yeah, thank you.
Can I make a comment? Is pay the right word? I'm throwing it out there. It is a stipend. So I know at the end of the day, there's dollars that support residents, but I just want to be careful on, I saw that on the survey, but is pay the right word? I know at the end of the day, but it is I think the official term is a stipend. And nowhere else in healthcare do we actually pay a stipend. We don't do it for nurses and others. So I just want to be mindful of that we don't create some disparity from other fields that we're trying to grow, nurses and others. So I don't know. I'm throwing it out to the deans and, Chris, you've got a cost report. But is stipend or pay? I just don't want that to become a sticking point with us.
This is just a survey. I don't think we need, sorry, Chris. I mean, I wouldn't worry too much about it. It was just the survey. We use the actual terms in the statute for other things, but we will take that into mind. Thank you.
I think the piece that's important to note is it's Mason is speaking from the chair he's sitting in, which is from the hospital perspective, it's a stipend in the contract or an amount in the contract, because we don't pay residents directly, and it's pay to the schools who employ the physicians. So everybody's right. It just depends on,
We pay you guys. Yeah, we pay. It's a payment for us. Yeah. But we're happy to clarify it, what it goes to as a stipend, but it's not an official document or anything. It's just to get feedback.
Yeah, I just from the committee, I agree with the dean's point. Being competitive, the increase of unionizations throughout the country. I think that's important that this committee statewide needs to look at that we don't want to create disparities, even within programs, within regions, within the state of Nevada. So I agree with you, Dean, on the concept. I just wanted to make sure the committee is using the right word.
Perfect. All right. Thank you. Okay, with that, I think we'll go ahead and close out that agenda item and move on to the next one. Introduction and discussion of the GME Advisory Council bylaws. So I'm going to share my screen again. And I'm just going to walk through the bylaws document with the council. And if you have any questions or concerns as we walk through, please feel free to raise them. So first, in Article 1, we just go over some of our general definitions that we're going to be using throughout the document. Article 2, we wanted to establish, some of the background and why for, why this advisory council exists and what it intends to combat and, I guess, what is the word I'm looking for? What it intends to, the problem.
Accomplish.
Yes, accomplishment. Oh my gosh, okay.
There's no coffee in this.
Yes,
room,
there's
That's
no
your
coffee.
problem.
Yeah, so just provided, some history there in that section. Talked about the grant rounds of funding, and they generally occur annually, and that the council provides critical support to the grant program, of course, and evaluates applications, all that good stuff. And then moving on to the number of members is just, the number of members that's required for those Senate bills. Conflict of interest. This I just wanted to make a clarification on. Members were asked to complete the conflict of interest form, noting any potential conflicts of interest that the public might see as a potential conflict as the council goes about its business. The having a conflict of interest does not preclude a council member from voting. And Gabe, is there anything else additional that you think that I should mention in the conflict of interest, or Lauren?
No, I would agree with what you just said, Melinda. The most important thing for conflicts is a lot of people think that any conflict prohibits them from voting. That's not the case. The most important thing is that if you think that you have something, disclose it so that everything's absolutely transparent. Thank you.
Great, thank you, Gabe.
So I have a question, in that first paragraph. It looks like it says, if you state your conflict, then you will recuse yourself from voting. So to me, it looks like it says you can't vote, and you're saying you can vote.
Is this the financial?
It's the affiliation. It says that if you're affiliated, then you shouldn't vote, basically.
This is Dr. Leon Raven, if you don't mind me commenting. I think affiliation meant to say financial relationship with the institution. However, it's not really the right term in my mind, because, for example, I'm a volunteer faculty with several institutions. I teach for some others. I am not a paid faculty there. And I think the better term would be to describe a member who is a paid faculty or can benefit financially from that institution. Otherwise, you will take community appointments for volunteer faculty are pretty common, both across the whole state. And those kind of appointments don't necessarily have any financial relationship with the institution. So just if you use affiliation as an umbrella term, you may go way beyond the financial conflicts that you're trying to capture.
Melinda, may I suggest a simple fix?
Sure.
Change the word shall to may, and I think it would,
the
allow
member
some-
may,
yes.
may recuse
Instead shall,
themselves.
just say member may. I think that's more appropriate.
I agree.
What are
May,
your-
I agree. May is more appropriate, and it really comes down to a case-by-case decision. When in doubt, disclose, and then Melinda and we can discuss that, look at that. But probably in the vast majority of instances, voting will still be allowed.
Perfect.
Can I also ask, again, Leon Raven for the record, well, should we consider any financial interest of family members of the committee members, just in case if there are some conflicts of interest there?
I think that is implied in the ethics statute. I'm not sure if that is really implied in the ethics rules already.
Right, the ethics that you all had to adhere to by being members of the council. Yep. Any other comments on the conflict of interest section?
Yeah, I have a question. Are we differentiating between voting and actually scoring of potential applications? If you represent an institution, are you then, you're recusing yourself from scoring and or voting, or is it one and the same, or?
Gabe, I'm gonna look to you to help me with that one.
I mean, I'm not sure how they're going to do it. Is there something in the bylaws that specifically states how they're going to do this? I would expect the scoring to be kind of essentially almost affiliated with a vote or associated with a vote to score it.
Yeah, I mean, it says, for making specific motions or casting a vote, I would argue that by scoring, that's your, vote for that application. So just ensuring that you disclose any potential conflicts before you vote.
For the record, I'm not supposed to do that, but it's likely that, as with many grants, we will have a scoring rubric before the vote.
Mhm.
Otherwise, it's going to be overly holistic, if you will. And so I think there is a point about whether or not the member recuses themselves from the scoring if there is a conflict as well. So that's something I think we have to just think through.
Should we add, from making specific motion or casting a vote or score, or a score or vote, and that the member may recuse themselves?
Well, just say making specific motions, comma, participating in the scoring rubric or casting a vote.
Yeah.
Okay. All right. Perfect. Thank you all. Okay, going to move on to membership, officers, and assistants. So the appointment, all members of the council serve at the pleasure of the governor. Appointment requirements, this just goes through, basically what's in statute of each of the member positions for the council. The term of each member is 3 years. And each member is obviously expected to participate in a majority of the meetings. And then we will talk about the chair and the vice chair in a moment.
So Melinda,
Sorry, can I interrupt?
Sorry.
Leon Raven
Go
for
ahead.
the record. I have a question about the statement that vacancies must be filled within 30 days. I am also serving on the statewide committee for school safety, and I can tell you, it can take easily months to get somebody on the committee, even if you have an eligible applicant. Sometimes we're waiting for the governor's office to approve eligible candidate may take several months. Let's be realistic. It's like the phrase must be filled in 30 days to me, just not very realistic.
Yes, thank you for that comment. And I'm trying to look because that
Melinda,
might
I
have
think
been.
that's a statutory requirement.
Yes, it is.
So we'll do our best, but this is the reality
Yep.
we have to live under state law. There's no penalty, but I can tell you this is a high priority for the governor's office. Hence, we're meeting right now and we got this full board, so they will move positions if we would need them to.
Thanks, Stacy. And
Just
Dr.
just one point. There are a number of us on this advisory council whose terms end in 2027, and that's because we were named as members a number of years ago. The council never met, so it was on paper only. I assume this is a statutory requirement. There's no way around that, but
No.
okay.
Yeah,
Well, this happen, we will communicate with the governor's office prior to that, and they'll send you a letter and tell you you can reapply.
Okay, fair enough. Thank you, Stacey.
Yeah.
Loss of institutional knowledge, I think, is what we're speaking of too.
Right, yeah. So that was a question I was going to ask the group. Do we need in our bylaws anything that addresses the opportunity to be reappointed? I get you'd have to be reappointed. Should
No,
we address
Chris.
that at all?
It's a standard process. I wouldn't want to put that in there and then someone challenge that later. Yeah.
I got you. Thanks.
Okay. All right, we're going to select a chair and vice chair today, which will hold office for 1 year and may be reselected. Staff assistance is just notes that the Nevada Health Authority will provide staff assistance and technical assistance to enable the council to accomplish its functions and duty. Meetings, council should meet at the call of the chair as often as necessary. Agenda, the Nevada Health Authority staff in coordination with the chair will be responsible for drafting an agenda.
Melinda?
Sorry. This is Dr. Fry for the record. It may be useful to put a minimum meeting standard of twice a year or something like that so that we don't get off track because there is no minimum standard here. So
Melinda, isn't
If
there
it's
one
only
in
if it-
statute? Wasn't there one in statute in Pazina's bill? Let us double check. If there isn't, we'll put in 2 times a year. But you can't enforce it unless it's in state law, just be honest.
Okay. Mostly I say that, Stacy, because it calls out later that the chair and the council, because of absences, may decide to ask for that position to be replaced, right? So.
Okay, thank you.
Hey, Melinda, I
was
just
there
wanted to
another
point out,
comment?
Thanks, Kate.
sorry, Melinda. Hey, I just wanted
Go
to point
ahead,
out you have there's a typo in section 2. I don't think it's NRS chapter 214. I am pretty sure it's 241.
Oh, gosh, thank you so much. Okay. Let's see, minutes. So we're recording this meeting. Minutes will be available. We will also post the meeting recordings. Voting. And then we get into functions and duties. So the purpose of the council, all of these items came out of the bill or different statutory references. So basically, talks about what are the main priorities of the council that I did review with the council earlier today. So those should all be pretty standard. Any comments on this section? Okay. Moving on. We've got exhibits, so just, reports, recommendations, obviously, council could be involved in. The council, within reasonable availability, timing, and accommodation, will provide medical field related briefings to the Nevada Health Authority when requested. So that goes along with, the council duties of being that advisory body. Compensation, this is all in statute, very standard language for compensation for members. And, further adoption and amendments to the bylaws in your time. So with that, do we have any other discussion on the bylaws?
Melinda, Paul Hapman for the record. So are all meetings open to the public?
Yes. Yes.
Including the deliberations or selection of programs?
I believe so. Gabe, can you help me on that one?
I would think especially the deliberations. I think that's the type of thing that would be transparent. If there's something that would be proprietary, perhaps that would not be, open to the public, but it would be generally expected that these are done pursuant to the open meeting law. And in Nevada, we really strive to have everything done as transparent as possible.
Thanks, Gabe. Okay, with that, I would like to entertain a motion to approve the bylaw.
Leon Raven for the record, motion to approve.
Do I have a second?
Second.
Perfect. Great. We have a motion and a second. All in favor, please say aye.
Aye.
All opposed? Perfect. Motion passes. Thank you. Okay. All right.
Get through bylaws.
Solid.
Got through the
It's the
bylaws.
fastest bylaws revision I've ever seen.
Perfect. Okay, so next we have discussion and voting for the council chair and vice chair. So I wanted to open the floor for discussion. Anybody who would like to be the chair or the vice chair, please feel free to, raise your hand and, maybe just address the group and why you would like to hold that position. And I'll open the floor for the chair discussion first. So anybody who would like to be the chair.
This is Mason Van Howling for the record. I would like to nominate Christine Bossi for chair. Sorry, Chris. Just because, and I'm going to explain why. just her decades of being here in Nevada, understanding her strong financial acumen, her understanding of GME, being part of it since the beginning, her strong support of clinical efforts in the state, throughout the state, her ability to work with everyone and be able to communicate and on her legislative side and government relations side. And honestly, Chris is a great facilitator, and if she doesn't have the answer, she goes and finds it with the most credible and valued source. So I'm making that nomination. So sorry, Chris, to surprise you.
Thanks, Mason.
Thank you.
As Dr. Fry, for the record, I would second that.
Thank you. Any other discussion on the chair? All right. I would like to entertain a motion for Chris Bossy to serve as chair at the Future Advisory Council meeting for the period of 1 year. Would anybody like to make a motion?
Leo Ray, for the record, motion to nominate.
Thank you. Second, perfect. We have a motion and a second. All in favor, please say aye.
Aye.
All opposed? Motion carries. Chris, congratulations.
Thank you. Thanks, Mason.
All right. Now I'd like to open discussion for vice chair.
Can I nominate Dr. Netsky for vice chair?
All right.
I would second that.
Any discussion on that at all? Okay. All right. I would like to call for, oh, go ahead, Mason.
That's the person.
Oh, I would just like to say I would be honored to serve in that position. I am happy and would be honored to work with Chris Bossy in this role.
Thank you, Dr. Netsky. All right. So I'd like to entertain a motion for Dr. Netsky to serve as vice chair. Do I have a motion?
So move.
Do you have a second?
Second.
Okay, perfect. I have a motion and a second. All in favor, please say aye.
Aye.
Any opposed? All right, motion carries. Dr. Netsky, congratulations. Vice chair. Perfect.
Get to work.
All right. Okay, now we'll move on to our next item, the briefing on current state of physician workforce in Nevada. So I'm going to turn it over to Dr. Packham, and I'm going to get the presentation started. 1 moment. Go to the next one.
All right, yeah, thank you. Melinda and Stacy reached out to me a couple of weeks ago to see if I could provide a brief, and I'm going to try to live to the word brief on this briefing. But a word or two about the Workforce Research Center that I mentioned earlier. Just wanted to share what I do in every presentation, which is kind of the mission vision of that center. And one of the operative words in that is trying to bring to bear the best data we can to inform health workforce planning and development in the state. A lot of the work of our office is really geared to that. Likewise, we're hoping that we can be of assistance to policymakers and policymaking boards such as the GME Advisory Council, literally to inform the kind of investments that we'll be talking about going forward to see if we're getting that bang for the buck, but more importantly, moving the needle on physician workforce shortages. Next. Just wanted to share a couple of flagship publications and resources from the office. Every other year in advance of the legislative session, we put together a Rural and Frontier Health Data book. It's actually more than Rural and Frontier, but we try to highlight county level health and population health, healthcare, insurance indicators as well as workforce metrics. A lot of that historical data is archived in our Instant Atlas, which again, I encourage you to check out whether you're writing a grant or thinking about how your county might stack up to others in Nevada. That is a great resource. And then finally, our healthcare careers manual, which is now in its 7th edition, and we're working on an 8th edition. This is used in every school district to do what I think is complements the work of development efforts such as GME, and that is to start having conversations earlier rather than later. Earlier is middle school, but certainly high school students on healthcare careers, employment opportunities, and the like in the state of Nevada. Today, and I hope everyone on the council got these reports. Next, please. Today, I'm going to be largely speaking from 2 recent reports from the Nevada Health Workforce Research Center. These are annual reports that we update each year. In particular, the GME Trends Survey is something that we have done for 21 years, goes back to 2004. And both of these reports are somewhat snapshots, and I just want to let the council know and staff know that we have a lot of data that doesn't necessarily find its way into these reports that I think could inform the work of the council. The GME Trends Report, for example, has granular data for each GME program, each residency and fellowship program, going back to 2004 that might speak to programs that are doing a better job than others in retaining physicians in the state and some of the reasons why. Next. I wanted to kick this off and provide, next please, a little backdrop on physician workforce shortages by just sharing again a little bit of data that we have collected. One of the ways that I like to frame workforce shortages, including physician workforce shortages, is a strategy that we've used now for about the last 6 or 7 years to talk about what would it take Nevada industry level, occupational level, facility level, and so forth. What would it take to bring Nevada to a national metric in terms of employment? We look at industry sectors within the health services and medical sector. These numbers are staggering. I double and triple check these estimates because they really leap out at you. And that is pick your industry within the health services sector and the number of jobs, including physicians and medical staff, but also folks down to med assistants, rad techs, and so forth. Some staggering healthcare needs. Likewise, next slide. If we look at the occupational level, these ones I quadruple check because I sometimes don't believe the numbers. But again, if we look at per capita metrics at the national level versus what we have in Nevada, these are the additional numbers that we would need just to meet the national metrics. These numbers don't speak to additional need, which I suspect in many cases understates how far we are in terms of what we need as a state. A long way of saying there is a lot of unfinished business in the state when it comes to health workforce shortages. And the registered nurses is one that has been an identified need for a couple of decades. If I get a little frosty when I hear somebody say we don't have a nursing shortage, this is one of the types of data I like to point to. We are facing a current projected nursing shortage.
John?
Yeah.
Quick question, Dr. Fry, for the record. The physician assistant shortage 355, what do you have any numbers on, I guess, the broader APP category, specifically including nurse practitioners?
I have all of that at the occupational level. So yeah. We could roll it up, whatever.
Just trying to understand, because I think the APP in general category is part of the solution to our state woes. Certainly not all of it, but as we approach the one big beautiful bill, 50 billion money, I mean, I think that's clearly a target for those rural counties that are underserved.
Yeah, and I don't include it in this presentation, but our data on advanced practice nurses, for example, we've tripled the number of advanced practice licensed in this state. We didn't really do it by expanding programs. We did it when we granted in 2013 advanced practice nurses the ability to practice independent of physician supervision, some limited prescribing authority and the like. And we have absolutely moved the needle on that. So, yeah. The final slides kind of in this backdrop on workforce shortages are ones that may be familiar to folks. We update these also on an annual basis. And what they highlight is literally down to the census tract level are shortages, utilizing data from the Health Resources and Services Administration, who works with state primary care offices such as ours on identifying areas that are short. These are also the thing I like about the shortage and designations and so forth. It's not simply a provider metric that's informing which areas are short and which ones have severe shortages. The darker the blue in this map, the more severe the shortage. They also speak to areas with higher levels of poverty, greater adult or child care, not child care, child health care needs and so forth. So it captures a lot, but this will give you a flavor of where we're short when it comes to primary care. The thing I want to always highlight on this is, despite a lot of that progress that I mentioned with respect to advanced practice nurses and so forth, we have enduring primary care challenges in this state. Roughly 2/3 of the state reside in a federally designated primary care HPSA. Put on my rural healthcare hat for a moment. These are very enduring issues in rural parts of the state. Those areas up in Elko County that are currently not designated as a primary care shortage, all you need is one physician to retire, leave the community, move to Reno, et cetera, and then you flip back into a shortage designation. Next slide. A final one again on the backdrop is the mother of all shortages, and that is mental and behavioral health shortages. Roughly 9 in 10 Nevadans reside in a mental health professional shortage areas, and that includes all 14 counties, which countywide they are shortage areas. And I want to turn to specifically kind of the reason I was asked to present today, and that's physician workforce trends in the state. The good news, bad news of this is we've actually made substantial progress over the past decade, actually over the last 15 years or so, in increasing the number of licensed physicians in the state of Nevada. About a 28% increase over the past decade. However, and this is a however that applies to many occupations in Nevada, when we adjust for population growth, which has been steady over the past decade, and through at least a couple of recessions since I've lived in Nevada, the growth in the number per cap has been a more modest 20%. One of the fascinating things about the licensure data that we've been chewing on over the last couple of years is the remarkably large number of out-of-state physicians that are licensed. That got quite a bump during the pandemic. And if you look at the next slide, Melinda, I've broken those, and these are just licensure counts. If you look at licensure counts by region in the state, I've got Washoe is at the top end, UNR blue, Clark's the red line, and UNLV red. And then again, more modest numbers in rural and northern Nevada. And this is the first time I put the out-of-state licenses there. It's interesting. I don't know what it means. I'm still not sure why those numbers are literally going off the chart, but there's now more physicians living out
That's
of
the
state
compact.
with a Nevada license than in Clark County.
Yeah, the compact
So-
that we entered into.
Yeah, the compact and the like. I always try to caution that does not necessarily mean that they are a pool of labor out there providing medical care, although some limited telemedicine.
So John,
Yeah.
I have called the question because we had so many compact licensure applicants that were successful, especially during the pandemic, as to can we get at how often they are actually working in the state of Nevada? It's very difficult to get at that. So in any way that we can in the future get at that, certainly using board data and other state data would be useful, I think.
Yeah, and I just bring it to the group's attention because I think there will be some people, well, we're not tapping into this pool of out-of-state licensees, and I would really caution. I'm not sure how much care is going to be provided by that contingent. It's just an interesting trend. Next slide.
Can I ask a quick question about this?
Yeah.
The data itself, is this only unrestricted licenses, or is this also inclusive of trainees who are licensed in the state?
No, I should have pointed that out. These are active individuals with an active license with the state.
Thank you.
Again, to echo or illustrate what I mentioned earlier, and that is we've seen a steady growth in licensing in medicine, nursing, and other fields and so forth. But these are all numbers that have been adjusted for population using estimates from the state demographer's office. And again, kind of what you see is much more modest growth rates, but growth rates nonetheless. And this looks at the number of physicians, all specialties from 2014 to 2024. Northern Nevada has and continues to fare better than that state average. The Clark County metrics there, again, they're all improving, they're all increasing, but still a substantial amount of work to go. And depending on how fast our population grows, that's a challenge for this state. I used to say we're treading water. Not really. I think we're making progress here. But again, the way we adjust these numbers.
John, I have a question.
Yeah.
Do you have the national average
The national average.
in reportable in the same way? Just so, I mean, I'm assuming it would be above all the numbers on that.
Substantially higher. Please don't hold me to this. I believe the national number right now is at about 300 physicians.
So Washoe County is above
Yeah,
the national average.
yeah. Just don't tell anybody. There's
Doesn't feel like it.
again, yeah. Well, again, please bear in mind these are licensure counts. They don't speak to what I suspect is the case in Northern Nevada. You've got an older physician population and many specialties that are going to be retiring out and the like. You don't have the in-migration to Clark County like is the case with Clark County. When I see the new number of licensees that comes out every quarter from the board, it's staggering how many are coming to.
And we can't normalize that to FTEs like we do at the university level, which would be, I think, incredibly useful when we're talking about, whether we're truly 230 or actually maybe we're, because of FTE equivalent, maybe we're more like 190 or 180.
Right.
We could normalize it if we had better data, but
Right.
and I'll have a beer with you and discuss that. We've got
Or three.
we've got a project in progress. Actually, this licensure renewal data collection project, and I think that would inform that number. So in conclusion on just physicians, next slide, please. Just a couple of points I wanted to make. And this is utilizing not the licensure data, but AMA master file that we purchase every year. What we see right now is out of the 37 specialty areas that they track, our numbers per cap are lower for all of those specialty areas except anesthesiology and forensic pathology. Somebody may have a good explanation for that. And as I noted on a previous slide, we're 2,300 we'd need 2,300 additional docs to meet that national average. I've also got data drilled down to the specialty level and included a couple of here that we're keeping our eye on. Family medicine, pediatrics, psychiatry continue to be hovering below the national average. I want to conclude with a few slides and some data again from this report and survey that we've undertaken every year since 2004. It's a survey that we undertake it's an extensive survey. I encourage you to look at the questionnaire because I think there's data that we're sitting on that could inform the work of this group. But at the heart of our study is to find out on July 1st of each year whether physicians completing residencies and fellowship are staying in Nevada, are they going on for additional training or beginning to earn a paycheck, not a stipend. This is data to kind of frame this discussion from the American Medical Association. I've got a soft spot for cheesy baseball movies, so I'm using this phrase, if you build it, they will come, and they do. Nevada actually, while numerators and denominators are small, we have a pretty good track rating. We never rank in the top 25 in anything health-wise, but we do in terms of those completing their undergraduate medical education, MD and DO, as well as GME. And as was noted earlier, when you do both, and again, this is a look back on physicians that began getting medical degrees in the state in the early 70s. So it's the entire suite of those actively practicing in the United States. We do well with respect to GME grads currently practicing, but more importantly, if you can seal the deal with somebody who received their MD or DO in the state with GME opportunities here, we do a good job of retaining those. A couple of additional slides I wanted to share. This is data from the ACGME, or the Accreditation Council on Graduate Medical Education. They dovetail some of the award information that was listed earlier. This is a really good story in that what you saw was relatively flat growth in the number of residency programs, fellowship programs, and even sponsoring institutions in the state. And with the advent of these GME grants that came out of legislation and signed into law by then Governor Sandoval, we saw a pretty dramatic growth in the number of programs, and again, even the sponsoring institutions. Those numbers at the far end are the old University of Nevada, Reno, or University of Nevada School of Medicine before UNLV was created and so forth. Even better, next slide. What we've seen again is you just kind of draw a line in this graph to highlight the role of the grant programs. The blue line is total residents. This is residents enrolled in GME programs in Nevada. Fellows, a much smaller number down the bottom. And then the dark line at the top is, again, these numbers rolled up. So those grant dollars were used to build additional capacity, and they were successful in attracting new residents and fellows. It's important to point out, not all residency and fellowship programs do that every year. There's vacancies in a lot of programs in other states. Not the case in Nevada. And then finally, yeah, go ahead, Brett.
I was wondering, Brett Fry, has the Office of Economic Development since 2015 been involved in some of these discussions and, weighed in or participated in how to, uplift this?
Absolutely, and it's not a coincidence that Vance Farrow is on this committee. That's by design. I think there's been a recognition from both Democrat and Republican governors that this is an economic development issue. So short answer is yes. Finally, I wanted to just highlight again, and this is a reflection of the previous two slides. and that is you build them, they not only come, but these are our graduation stats. I would kind of point out that if you look at any of these on an annual level, these are still, in some respects, small potatoes, graduating 46 fellows in the state of 3.3 million people. That's a small number, and again, a lot of unfinished business. Final two slides I wanted to share with you. These slides are a little busy, but what they provide.
Before we go on, can I
Yeah.
ask a quick question? Jeremy Kilburn.
Sure.
Do we have any data on number of spots that were sponsored by the VA or the DoD, or I should say DOW nowadays? But do we track that data at all? Federally funded spots?
Yeah, the short answer is yes and no. We've collected a little bit of that, and kind of for example, is the geriatric fellowship that we've worked on and with Renown and the VA and so forth. But what I would, and so the Department of Defense ones we don't, and kind of what I've tried to focus in is accredited programs that meet what I would call the civilian workforce. I don't know what the appropriate term is, the civilian workforce, but I'd lean on this council to ask if that's important data that we need to begin collecting. I think it's important. The other thing that we don't collect data in is non-accredited GME, particularly fellowship programs. There's orthopedic fellowships all around, and oftentimes they're fellows coming to Lake Tahoe to work on an orthopedic fellowship, and then they go back to Pittsburgh and Poughkeepsie and other places. So, but hopefully I'm not dodging that question because we're interested in collecting data that needs to inform the work of this group, and so going forward, I'm happy to make those kind of adjustments.
John, if you just go back one slide.
Let's go back one slide.
For the record, you know, it's interesting. If you look at the 274 graduated this year, if we use your 60 to 80%, 60% completing GME stay in the state, 80% if they went to medical school, let's say it's 70% of that, you know, you're what, 160, 170, and we have the gap of 2,300, and the state is growing. It would take 15 years to even get, you know, at the rate we're going. So it's a really strong argument in favor of expanding GME.
Yeah.
And the aging of.
Yeah,
our
and the aging
workforce.
of the population, so the healthcare needs are going up.
Those
So-
are, and I'm even saying the aging of this workforce, because we have some like, I looked through some of your pages in your book, and there's a big chunk that's over 55.
Yeah.
Washoe is much older than Clark.
Yeah.
Yeah.
Sure.
And the other element to take into account also is that you may not be getting a full 1.0 FTE out of every graduate too, because their viewpoints of current trainees are very different in terms of the viewpoints of previous generation of workers. So you may not get as many clinical hours out of each graduate, which means you might even need proportionally larger numbers of graduates.
This next slide, just wanted to highlight, on the left is a kind of a crosstab of data from the survey this year. We graduated 274 residents and fellows in the state. The number I kind of like to highlight is that those who are going to continue additional training, but leave the state for fellowship training, subspecialty training. That's a number that we've seen kind of increase over the last couple of years of conducting the survey. Again, this is what they told us on, you know, as of July 1 and leaving the state for this additional training. Many come back, but many don't. There's no guarantee. And so that's kind of my enduring concern is if we're not building those fellowship programs, have we just invested mightily on physicians who ultimately leave in that kind of that last part of the journey? If we look at that same data rolled up, that's 432 out of the 2,000 plus that have completed GME in the state. Imagine if we cut that number in half with fellowship programs in the state of Nevada over the next day, and we're capturing even a portion. You're going to capture all of them. People leave for a variety of really good reasons. They come back for a variety of good reasons that they tell us. But there's an opportunity in a concerning stat there. The way I would caution us to think about it, though, or not caution really, is the pie is expanding in terms of the number we're graduating, but there might be a slice of that that is growing on fellows or physicians completing GME that are leaving for fellowships in other states. Final slide. To extend my baseball metaphor, if you build it, they will come, but will they stay? And that's just a reiteration of what I pointed out earlier. And again, I was pleased to see on the survey results that Melinda and Stacy got that fellowship development is a priority. It jives with what I consider to be one of the biggest needs in physician workforce development in GME in Nevada. And with that, that's as brief as I can be.
May I make a comment?
Of course.
So the healthcare screening needs of the state are, I think, particularly concerning. When we can't meet the population health screening needs, we're already failing. And that's why I think we're 51st in some of those categories. So to the extent that we can focus on programs that will ultimately produce practitioners that can help us with population health metrics, especially healthcare screening, we'll just be in better shape.
Yeah. Well, it's interesting you point that out, that rural health transformation grant that our office is working with the health authority on. That's one of the 5 pillars of priority. So we were really happy to see that included as an eligible expense that we can pursue as a state, because we disguised the only direction we can go on that. So.
Leon, for the record, may I ask a question?
Of course.
So I'm curious how the data on growing in residency and fellowship slots correlates with the number of graduates from medical schools here in Nevada, and whether or not some of those graduates leave Nevada not because they want to, but because they just simply can't stay here to find the position in the residence based on the discipline they would want to practice. So we have some idea from those graphs how the residency and training fellowships are growing over time, but I'm not sure if they're growing fast enough to catch up to the number of graduates. We just opened a new medical school here in Las Vegas, so that's another 60 graduates in 4 years who will be looking for residency training positions. And just something that we could add to that graph, to those graphs, that would be great.
Yeah, my data don't speak to that, but I think you could speak with any medical school about when they parse through the match results, what's going on there. That same AAMC data set that I used for some of those slides highlights that we are #1 in the country in terms of percentage growth in new UME grads in the state of Nevada. So, but we need to put it in terms everybody already recognizes. We need to expand GME dramatically to seal that deal. Or those are individuals who leave the state with no prospect or promise necessarily that they will come back.
It's Wolfgang Gilia for the record. You know, every little wheel counts when you have a watch. And this is so important for recruitment of the best medical students, not only from the state, but also from other states who then want to stay here. If we can say we have adequate or better chances for you to stay because we have excellent GME, we can attract, I think, better students to all of our schools. And I really think together we work and build a number that is really powerful. So if there's any way we can open that kind of bottleneck at the end of their education, I think we can really make a big difference. And I like those numbers that, yes, we are one of the best states that actually is growing there. But we're also in competition with other states.
Yep.
Those numbers would be good to have.
Thank you.
Right. Thank you, Dr. Peckham. Any other questions, comments?
Just a
Okay.
quick comment,
Yeah.
Leah, and the record. I will be curious to see these numbers in about 2 to 3 years. So once we start seeing the real consequences of the foreign physician bill that was passed in the last legislative session, and how many foreign physicians will be able to get licensed bypassing residency training programs in the United States. Just a comment.
Yeah, thank you.
Yeah, I supported this. Supported this. Let's see.
All right, I'm going to move on to the next agenda item. I just got to pull up the presentation. There we go. All right, so let's talk about work planning. So this council, we have a whole year ahead of us. We have a lot of funding in the pot of sorts to be able to get out this year, and just wanted to kind of walk through some different timelines to talk about how the council might want to approach, its duties, I guess. Okay, so first, I wanted to talk through the GME timeline, the full process, right? When you start out as a ACGME accredited sponsoring institution, so you've already got the sponsoring institution. Well, there's the planning phase, right? You still have to find the sites, the teachers, design the curriculum, and sign contracts, and that can really take 6 to 12 months if we're being generous with our time there to really prepare and get that application submitted. So I just put some dates here to kind of help gauge the time frame that we would be going through. And so then, say that the institution decides to submit their application to the ACGME in November of 2026, and they also have to, submit information to the Resident Review Committee. And the Resident Review Committee may only meet 3 times a year. I don't know if that's true for all of the programs, but I think that that's pretty general there. And then, it can take another 4 to 12 months for the review committee to make an accreditation decision. So then you're looking, you started in February of 2026, and you're looking at, potential approval by May of 2027. Then you have to go through the match process, right? So register the program with the National Resident Matching Program, advertise that match, and then interview and rank, all that good stuff. And then that can take some time. So I did go to the website of the ACGME to kind of, review this information and present it to you all today. So, the June to March timeline is pretty spot on with, how long it takes to really complete that match. Some residents can be accepted outside of match, but generally I think that, usually follow the match process. So then you're looking at a start date of, July of 2028, right? Like you started in February of 26. And then you finally get to start with your first resident in July 2028. So it is quite a long process. So now I just kind of wanted to go through the next slide, which talks about, if you're already ready to submit an application, right? You've already done the planning process and ready to submit. So then, you're looking at same start date, right? February 26th, looking at approval of May 26th. And then June, looking for that match process to start, and then going through complete the match in March of 27, and then could actually look at starting a resident in July of 27. So, it takes a year out of the process, right? If you're already ready to submit applications. So this would be for like the GME programs that might have some pre-baked programs ready to go to submit an application to the advisory council for some funding. So we're looking at potentially a year there to be able for that program to start. Next, I kind of just wanted to give an overview of, the different steps to so that was the slides I just showed you was kind of more like the institution standpoint, and this standpoint is more like from the hospital standpoint, right? So looking at that time frame of, the pre-med, right? And then they go to med school for 4 years. And then we're really looking at that period of the GME residency and the GME fellowship. So the residency is where the student is paid a salary or stipend. And then the training in the various patient care settings and in residency as opposed to med school, right? Residency, do have primary patient care responsibilities. So that can be, a 3 to 7 year residency. And then there's the optional for the fellowship part. So that can be 1 to 3 years. Student is, again, paid a salary or stipend and receives that subspecialty training in various patient care settings and continues to have the patient care responsibilities. So I just highlighted there that, the residency and the fellowship is really where we're looking at that ACGME accreditation standpoint in the sponsoring institution. All right, so here I wanted to go through, the grant timeline, right? So let's tie all these things together. So we've got the institution standpoint, we've got the hospital standpoint, now we're looking at the GME grants, right? So I put a potential date out there of February of 26 for the council to meet, to discuss the progress of the current GME programs and prepare for the new round of funding applications. As I mentioned, we're looking to work with a vendor to work on the scoring rubric and, developing that objective nature of how the council can review all the applications. And I want to make sure that all the requirements and the priority standards that are outlined in statute are included in the application. So when, programs go to complete an application, they already know the expectations of the program and how they can kind of position themselves for, more points potentially if they meet more of those priorities. So starting in February 2026 there, then looking to open potentially the request for application, the RFA, around March of 26. So that would be live then. And then have that open. So I was thinking beginning of March, right, until the end of April to give them as much time as possible while still being mindful of time to be able to get the money out. So then close the grant the end of April and then have the application review in May. So that's where the advisory council would score all the applications and provide recommendations to the Nevada Health Authority for funding applications based upon those scores. And then looking at June of 26 to be able to sign the subgrant agreements and then start the grant in July of 26. Any questions, comments about any of those? You look like you have a question.
So Paul Hauptman for the record, the February 26 list of tasks is pretty monumental. I'm wondering whether a meeting in December, you have a new chair and co-chair, whether they would be willing to have us meet. Because I really think, I think just looking at current GME programs alone is a heavy lift. And then I do think we'll need some time to consider the rubric. It's going to be extremely important that we get consensus on the rubric. And I don't know when the vendor will have that available, but I would hope by December we would have a chance to review and then maybe finalize in February.
Mm-hmm.
But I'll leave that to the chair and coach.
Thank you.
Merry Christmas.
No, I absolutely agree, Dr. Hoffman, that we need time to prepare and
Mhm.
I don't know what the group, what the group's preference is, but it seems like there used to be a rubric I mean, so maybe we look at what was done before and pull it, dust it off, and then look at the things that are different now. And, if the group's willing, to start with that, along with identifying more specifically in the materials that John gave us around, where the biggest shortages are. We probably need a meeting of like educating ourselves about what programs currently exist and where, and, that kind of thing. And then identifying, where our shortages are, and then ending with the rubric, giving input into how we should prioritize.
Well, and we should also include in that discussion what programs are in the pipeline. I think we have kind of
yes.
siloed discussions across the state on what's kind of in the works and so forth, and that needs to
Sure.
be a part of it.
No, that's great.
Chris, do you think that some of this work virtually, like poking holes in the current rubric, may be useful to try to have some of this work be virtual and some in person?
Oh, I mean, I guess the group needs to decide, but I wouldn't start with the rubric only because I feel like we'll have to circle back to it once we get educated and have a sense of our priorities. But it's up to the group if you guys want to.
Would it be a potential for us to have the vendor potentially like look at the rubric that we have now and put together something additionally that could help us and then present that to the group in like December, right? Like have somebody already.
Could we, and we'd still be looking at also in December, our current inventory of programs.
Yeah,
Because I think, and the biggest shortage areas.
Yep.
Yeah, so I mean, I wouldn't want to lean in too hard on the rubric.
Yeah.
Until we kind of, because we'll just spin. Well, everybody will have their opinion and, until you know where
we want to
your big shortages are.
Yes. And Stacey, you have your hand up.
Chris, I love that. I think I would just recommend that we actually take an afternoon, like a real 4-hour meeting. I think if you guys really want to do this work and we want to get money out the door, we're going to need longer meetings, real working meetings, possibly small, like breaks in between there. But I think I agree on more meetings as well. But I think we need longer meetings where we're really producing more, if that makes sense. If folks are, I know we're all busy, but I think that's going to be needed.
Yep.
That makes sense to me. We'll have to.
Stacy, maybe a dumb question, but when we call for the RFA process outwards to the state, are we going to make any statement regarding our prioritization of needs? I mean, like pediatrics really stands out to everybody, right? So are we going to, invite to fill those gaps?
I think that's part of what we need to decide as our rubric, right? And what we're focused on. I will tell you from the governor's office perspective and at MVHA, we really want to see us focus on where the gaps are and we're going to get the most bang for our limited funds. And where we're actually going to feel the need. I think pediatrics, yes, but I would argue primary care. I would argue a lot of other things too. So I think that's part of the discussion and why we need to have time as a group, right, to think about what priorities do we want to focus on for this round, and where is the need the greatest, but also where can we actually have an impact, because we do have limited funds. It's not as much as I think we all know we need, but it's important. But I think if we could do some focus through this and put it out in our RFA, it would be very helpful to everyone, so we can be more focused.
I like that.
Other thoughts?
Other thoughts from the group? Yeah, I can't remember if I had another slide or not. Oh, I did. So, let's see. I went into, oh, yes. Okay, so SB 262 has additional language noting that the Nevada Health Authority may award limited grant program grants to these two items, which I thought was really innovative, right? So assisting institutions in building administrative and operational capacity to establish a new program for residency training and postdoctoral fellowships, and to recruit personnel essential to the operation of a program for residency training and postdoctoral fellowships. So I thought that that was really exciting because potentially we could include that, you know, in our RFA and get applications speaking to these two areas as well.
So correct me if I'm wrong, Dr. Hopman and Dean down south, but to me, that is describing startup costs. And these grants have always gone towards startup costs. So I think that's great. And
Right in
then
line
we
with
can
it.
do, yeah,
Yeah.
I think that's great.
I'm also seeing the words providing supplements to salaries in there, and it's in the same paragraph or as recruitment. Could any of this be utilized for resident recruitment also? Was it only going to be for the faculty recruitment aspect of it?
Good question. I'd have to go back and review the statute for the exact meaning of that.
If this
Just trying to think
language
outside the box here. Yeah.
Yeah, it's pretty much quoted from statute there.
then
so.
it looks like
I think-
setting up the training program. Yeah.
I think what we could do, guys, is talk to our counsel, and then also talk to LCB. We'll come back to the group with that.
Thanks.
Perfect. All right, let's see. And then here I just, I copied and pasted basically the slide that we went over before, and just, bringing that back to this discussion, as well on, our work planning. Okay, so basically, yeah, I had slated possibly November, but I mean, December is fine too for our next meeting. But I really like Stacy's suggestion of having, that big chunk of time, right, the 4 hours to really get some good work done, and have a strong direction forward. So
Do you know when we'll be ready
when we'll be ready
for a meeting of that nature, given we're gonna need materials to like look
Yeah.
through, and the sample rubric and the survey of all the GME programs and completed by program, so we can,
for sure.
like, I don't
December 5th.
know when that's.
Friday.
So Stacy-
That's board meetings. Okay.
Stacy's got her hand raised.
Yeah, I think, Chris, we're trying to get, remind me, Melinda, who got the bid for this work again? Was it Milliman or Mercer?
Milliman.
Milliman. So I think do we have to go to BOE, Melinda?
No.
Okay, so we just have to do a work order. Okay,
Yeah.
so we should be able to get Milliman on the board pretty quickly. Get them on board to start working on this. I think we should probably give them 3 to 4 weeks to help us start to really, if we're actually going to look at the landscape, they're going to need to talk to a lot of folks and help us put all that together. I know John Packham can help us too, and others, but maybe, I mean, we could definitely do one in December. I think that's fair, and possibly November. Depends on what all you guys want at that meeting, I think.
2 short meetings versus 1 long meeting, I think is maybe.
I will just say
Oh,
2 short meetings often don't land. I know you guys don't want to be here long, and maybe we do a break for like lunch and come back, but I just want to say, like, sometimes short meetings, we just get warmed up by the time you know what I mean? Like, it takes us a little bit to get warmed up. So, and maybe we can talk to Millen, and maybe do a 3-hour meeting with a break or something, and come back to make decisions. I just want to give us time for us to fully be briefed, and then for us to have real discussions, and maybe we take a break for lunch or something.
Oh, I think she's,
Yeah.
so Melinda, would you do like a doodle poll because we're gonna need a lot of people to like be able to look at their calendars, and of
Mhm.
course, we'd want the most attendance as possible.
Yep. Yeah, I'll do a
100%
doodle
would be-
poll.
Is that the best approach? So
Yeah.
we don't, okay.
Yeah, does that work for everybody if I just send out a doodle poll with some proposed dates and things, and hopefully we can get to 100% of the members available?
And I would rather err, and nobody throw anything at me, but I would rather err on the side of, we blocked 4 hours and we only needed 3.
Right.
And we can leave because we got our work done,
Yes.
than to not have landed the plane.
This is Leon Reagan for the record. Would it be possible to perhaps do doodle poll for the next 2 or 3 meetings, planning in advance? I don't know how other school schedules filling up. For me, long-term planning is quite important because sometimes I'm asked to do lectures or attend other events way in advance, and knowing that I have something blocked on my schedule helps me with that. So, we may find out that December attendance may be spotty, but everybody's here second week of January, for example, and it may be much more efficient from that perspective.
Yeah, thank you for that. I can definitely do that. I will send out doodle polls for the next few meetings, and I'm gonna ask for 4 hours in each of those chunks just to be on the safe side.
And then there are 2 blackout dates because Dr. Netsky and I will be busy with the Board of Regents December 4th and 5th.
Oh, thank you. Okay, so no December 4th and 5th.
So it sounds like there may be times where some of you may not be able to be there. I just want to say I understand, appreciate that. As long as we have a quorum, we can get the work done. I don't want to be in a place where we have to go back to the legislature and say we didn't meet it. I mean, I want to get the work done. I know you guys do too. And so I am going to push us to meet because this is really important to us to get this money out the door. So we will look at everyone's options, but we're going to have a meeting, as many meetings before the end of this year, and we will have other meetings too. And maybe some folks can join virtually for part of the meeting. But I just, there's going to be times where not everyone can be there, and it's just going to be the reality. And I just want to recognize that because this is urgent, and we need to move these funds. So thank you.
Is there any opportunity for us to consider non-meeting times also where we're actually working online together? There's a lot of things we can come to consensuses on. We can make.
No, it has to be open public record.
Violate open meeting laws.
Yeah, we'll violate public record. You can do it online if we want to do a virtual meeting, but we cannot be going behind offline doing things.
I'm not talking about meeting time. I'm talking about we're not even allowed to look at materials without it being in the same room together.
You can do that. You can review materials ahead of time, which we will get to you. That's part of the plan. But any decisions, any recommendations, you could maybe submit your recommendations in writing before the meeting and we could read them if that's helpful.
Even
I'm
conversation.
just trying to think of ways that we could be more efficient as a group too, because if we could only make decisions in a room, then it makes us less nimble as a council. And I think we can accomplish more if we're able to at least read everything in advance, come to the room with some ideas, and that way at least it's not the first time we're seeing the materials.
Oh, for sure. I don't think that's a problem, but any emails to each other about where you want to land cannot be happening. And Gabe, I see you come off mute. Help me clarify that.
Yeah, I was just about to pipe in just to echo what Stacy just said. So certainly you can read information and you can prepare information, and it's okay for you to respond to Melinda if you have concerns or comments, but do not send emails to each other. That can sometimes lead to serial communications where even perhaps if you only email one other member of the council, if that member then emails somebody else down the council, it becomes a serial communication, which could be a potential violation of the open meeting law. So don't do that. All deliberations need to be in public.
Thank you.
Okay. So, all right. So I'm going to send some doodle polls. We're going to meet with our, Stacy and I will meet with our vendor and talk about how we're going to put that together. And I think with that, and close out another discussion. Okay, perfect. All right. So moving on to the next item on the agenda, we've got public comment. So again, no action may be taken upon a matter raised under public comment period unless the matter itself has been specifically included on the agenda as an action item. And I would like to call for any public comments. You can use the raise hand in Teams feature or just raise your hand. Any public comment? Okay, seeing none. We will go ahead and adjourn the meeting at 11:53 a.m. Thank you all so much for your time today. I really appreciate you all in this excellent meeting. Thank you.
Congratulations, James. Well done.
Thank you.
Brett, do you have 1 minute?
You guys.
Yeah. That would be good.
It's all right.